Wonderful, thank you. Yeah, so I'm going to talk today a little bit about the work we've done over the last couple of years now, and unfortunately it's taken a bit longer than anticipated, looking at symptom documentation and trying to really expand the breadth of what we're seeing in terms of the literature for symptoms in CTX, and then trying to touch on the management recommendations going through. We go to the next slide. So just some disclosures on the Medical Scientific Advisory Board for CTXA, and then this Hunter's Hope has kindly funded this work through this. Next slide. So what is CTX? We've had a number of talks. I know Andrea DeBarber talked about it, and then Dr. Larson did a great job kind of talking about his work in it. You know, generally a rare genetic disorder that has to do with cholesterol synthesis, going into the chenodeoxycholic acid and cholic acid, and then causing this increased disease-causing compounds, including fatty deposits, particularly the xanthomas, which we see clearly in the tendons, but elsewhere as well. So next slide. First described in 1937. There's been a lot done in terms of the biochemical understanding of what's going on with CTX and with this cholesterol synthesis and metabolism as we go through. Our hopes as we went through this project and as we started this was to highlight the high symptom burden in our chronic patients of CTX and really expand and provide a listing of some of the symptom management options that might be available when we think about each individual symptom going through this. And we're hoping to get this out of the literature, which has proven a little bit difficult, which we'll talk about. But you know, when we were going through, we recognized that there were going to be knowledge gaps in the literature. And that was one of the things that we talked about on the front end here, and making sure that as we went through our results and our knowledge that we were coming out was what some of the gaps of knowledge were within that clinical aspect. So next slide. So we did a literature review looking at papers published from 2016, which was there was the paper that Dr. Larson had brought up from Dr. Eichler's group back then that had looked at papers prior to that through 2019, which would have been kind of right where we were when we had done this. So this was extending that literature review from the 2016. And then we looked to expand and update our patient case series. So we had reviewed, I believe it was 4 or 5 patients previously, and we now have about 10 patients that we're following. So our goal was to update the clinical presentations that we were reporting from our literature for the previously reported patients, and then include the new patients that were in our group. We characterized them similar to the previous review in terms of neurologic abnormalities and non-neurologic abnormalities. We did break down some of the psychiatric abnormalities after talking with a number of CTX families and trying to get a sense of what symptoms we should be looking at from them. Where were they seeing symptoms? What were they hearing about in the community? And what should we be evaluating the literature and our chart review to make sure that we were capturing? And so we did try to break it down a little bit more granularly, which may be a little bit different than some of the other work that's being done on CTX currently. So next slide. So historically, you know, these are the symptoms that we really hear about frequently. Chronic diarrhea at an early age, there's early cataracts, there's kind of the classics that we think about. Xanthomas, tendon xanthomas that you can see in the pictures here. These bumps are where the arrows are. And then some of our more classic neurologic symptoms, including speech impairments, balance issues, spasticity, and then, you know, impulsivity and other behavioral changes have been described, but it was relatively broad as we were going through. So if you go to the next slide, this was the symptom list that we had put together after a number of meetings and discussions that we were looking to pull out of the literature as we went through a number of papers, and then again also through our chart review. And so you can see it was a bit more detailed as we were going through, and we were trying to really specify exactly what was going on as we thought about each one of these categories of symptoms. So within the neurologic symptoms, there's a lot of the classic symptoms: the spasticity, gait difficulties, cognitive decline, you know, ataxia is a classic one that we talk about, sensory changes, tremors. The psychiatric, we really did our best. We were hoping to break down some of the psychiatric symptoms that we may be seeing in these patients from early symptoms such as learning difficulties or attention problems to potential later issues like hallucinations or aggression, agitation, and go through there. The non-neurologic, a lot of the classic ones such as tendons, xanthomas, cataracts, and diarrhea. There were some other things that came up, including exercise intolerance and fatigability, which weren't well documented within the literature we looked at, but talked about by a number of the families. And then, some of the gaps that we think about in other diseases that have been well talked about by some of the previous speakers, like sialorrhea, bowel bladder issues, and then dystonia, things that we were hoping we would be able to pull out and see if this was something that was present. Sorry, I'm clicking the keyboard to switch slides. So neurologic, this is the data that we pulled, and it's a little bit different than what we're seeing in some of the other reviews that Dr. Larson had presented before. And I think he did a good job of talking about potentially why we might be seeing those. Some based on the age of our literature, the age of the papers that are coming out and how the diagnoses are being made. Additionally, the age of the patients that are being seen. So when we think about our patient population, we do have a bit of an older population. And so I think we're seeing, these psychiatric changes, and we've been talking about them more in clinic. And so I think we're seeing higher percentages than what are being reported elsewhere, but lower in some other aspects. So there are some differences here compared to some of the other literature, but I think, as you go through and you look at sort of the details of what papers you're looking at and the age of your patients, and that's where we are seeing them. If you could come to the next one. So our psychiatric abnormalities, you can see we kind of had a broad scope on the neurologics aspect when we were looking at it and just trying to capture anything that may be there. And often in a lot of the papers, that was something that we were seeing, is that it just talked about psychiatric changes and didn't really delve into what exactly was going on. Within the literature, which is the lighter color, there was very little reported. We did see discussions of autistic features, learning difficulties, depression, ADHD, and behavioral changes. But when we looked at our patient population, where we were looking a little bit further at them, I think we did see a bit more symptoms and more frequency in some of these different symptoms. Next slide. And then similarly for non-neurologic, you can see like tendon xanthomas. I think, as Dr. Larson had mentioned, a lot of the papers we were looking at and the patients that we were seeing, or the papers we were looking at in particular, were much more recent papers that were being published. And so the percentage of tendon xanthomas that was being reported was much lower. Similarly, within our group, we just happen to have a group that doesn't necessarily have a lot of presentation with that. So we did not have a huge number there. But we did see some sialorrhea. We saw some speech difficulties with that. We noted some bladder dysfunction as we were going through. So next slide. So, just thinking about our treatment options, CTX fortunately can be treated by an oral medication. CDCA is available and has been shown to be able to treat the biochemical abnormalities. There's still ongoing research, but it has been shown to have notable impact on symptoms. There's some question about how reversible things are, particularly when we think about the neurologic damage, and depending on when that treatment starts. When we think about our diagnoses for CTX, there's often a very delayed time between symptom onset and diagnosis. And so some of those long-standing neurologic deficits may be more unreversible. So, thinking about our newborn screens and that sort of early diagnosis and early treatment is always important. So next slide. When we looked at our populations and the papers that we were looking at, every one of our patients had been on chenodeoxycholic acid as we were going through. We did have one patient that switched over to cholic acid. It did come up in one discussion with families that there are some patients that are on both. We did not have any of them both at the same time. And then, looking at the other treatments that are reported in the literature, I find it hard to believe that none of these patients were getting any of these non-pharmacological interventions like therapies and bracing or muscle relaxants and that sort of thing. But it's not well reported out there. And so when we looked at our patients as we were going through, it's not a huge percentage of the patients that we were seeing. And some of that may relate to, how old and the age of the patient and how this progressive disease is coming on. But I do think it's present, and it's something that we were looking at and going through. So next slide. So when we think about the neurologic symptoms, there's certain ones that I think are a bit more important and more prevalent. And, I think it's important to kind of look at, how quickly these things are coming on. So when we think about our corticospinal tract abnormalities, spasticity, that sort of ataxia, our gait difficulties, which are probably a combination of the other things that we're talking about. By the time patients are 40 or so, there's about 50% of these patients that are having issues with this. And so when we're thinking about our symptom documentation, and then the second part of that, our symptom management, this is the thing that we're trying to focus on in terms of where to focus our energies as we're coming through, because there's some level of a lack of literature out there, and so we're trying to focus on the ones that are probably more prevalent for the patients as we go through. So next slide. And so ataxia seems to be one that has been pretty noticeable, and you can see that ataxia really has to do with the coordination of our motor system, and as we're going through this, and so it can affect a lot of different areas, from our speech to our eye movements, and particularly our gait. And so I'd like to talk a little bit about gait today. There's not a lot of literature focused on ataxia within CTX and how to treat that, but there are some other diseases out there that are primarily ataxic. And so when we think about how to treat this, I think it's important to think about what options are out there, because I've seen a number of patients, and I've had patients that have come to me, that have had bracing or other treatments that have been put onto them that have potentially worsened their function or made it more difficult to do the things they're doing. When we think about ataxia, the thing that comes to my mind is inconsistency. It's those patients that have difficulty with coordination in terms of their gait. They have inconsistent step patterns, inconsistent step lengths, and they're not always kind of right under their base of support. They have these steps that go a bit wider. And the important part with that is allowing that patient to be able to correct from that and not putting them in a position where they may fall. And so the things that have been looked at are much different than sort of our spastic patients, or that sort where we think about our AFOs and we think about our ankle foot orthoses. Patients I've seen that have had more solid or more robust AFOs have sometimes had difficulty where they take that inconsistent step and they're a bit wider, their foot's not under their base of support. And instead of being able to accommodate for that at their ankle and use all their joints to keep themselves balanced, they're required to do it just at their knee or just at their hip because their ankle is locked out. And they have, these perturbations that put them off balance or potentially cause them to fall. And so when we look at the literature, the things that we see in the literature that are helping with ataxic symptoms are much more about stability and that sort. And so, Dr. Evans had talked a bit about the DMO, and that's one of the ones that gets talked about quite a bit to increase that stability, that gait stability and trunk control in these ataxic patients. So when they do have that inconsistent step, when they do have that potential perturbation to their balance, they're nice and stable within their trunk, and they're able to pull themselves back because they're not getting too off balance on the upper aspect of things. And so that has been shown to be quite helpful when we're thinking about our ataxic patients going through. There have been some other, novel options. This was a study that looked at different knee design braces. They actually made these braces that were focused on trying to increase the stability of the knee. So there was one that was a spring-loaded one versus one that was more of a tension-loaded one. And the patient found that the spring-loaded one was better, but really what it did is it tried to get that knee back into a stable position and give them that support when they were in that standing spot. And so it wasn't taking over control. It wasn't limiting function or limiting movement too much in any one direction, but only enhancing some of the strength, some of the activation, some of the ability to stay stable underneath with their feet underneath them. And so, those are the types of things we want to think about when we're going through. Can we go to the next slide? AFOs, there's a whole slew of them. At times, they may be appropriate for our patients with CTX. There are patients that present with more of a spastic gait pattern. And there may be a reason to potentially think about a lower brace. So this one in the center, this kind of white bland one in the center there is what we would call an SMO, or supramalleolar AFO. And the thought with that is to provide a little bit of medial lateral support to the foot, potentially give a little bit of control to the arch and give a better positioning to the foot and give them more feedback as they're going through. That's not just coming through the bottom of the foot, but maybe through the entire ankle joint. And so that's often as high as I'll go with our ataxic patients. When we think about our other braces, you can see on the top is what would be like a metal double upright. The one next to that is a posterior leaf spring. So it's a solid one that kind of flexes with the intrinsic properties of the plastic. There are articulated braces like the one with the flags on the right. And then there's lower things such as the chipmunk or a UCBL that can help with kind of positioning of that foot and arch support as we go through. It's important to really think about what the cause of our gait dysfunction is and make sure that we're prescribing bracing similar to how we would think about, medications and that sort of thing. There are real potential negative side effects and adverse reactions, and the wrong brace can really have a negative effect. So making sure we're thinking about this on both sides and we're not just throwing bracing at, sorry, I'm standing still for too long, throwing bracing at these patients, but doing it in a thoughtful manner and in a team approach. And so most of the time when I have more difficult patients like this, I'm seeing the patient with my orthotist, with a PT, and we're really having a long discussion about what's going to be most appropriate with pretty close follow-up to make sure what we gave them is doing what we're looking for. Next slide. And so Dr. Evans did a great job talking about tone management and the different options. This is, I put this in there just as a look at sort of the breadth of different things that we have available for our patients. And that it used to be really clear that we would start at that top, stretching therapy, bracing. I used to see this described as more of a pyramid, but I think it's important to use this as appropriate for your patient. So stretching, bracing, therapy, that still is probably going to be the base, but it may look like therapy at home. It may look like those home exercise programs that Dr. Evans was talking about, or adaptive sports, depending on where we are and what's available to us. And then, in terms of our oral medications, the baclofens, the dopaminergics, the gabapentin, other antispasmodics versus focal tone management like Botox, I think it depends on what your goals are. Similar with the procedures and that sort. If your goal is really focused on one individual muscle, it may make a lot more sense to focus on that focal tone management and keep some of these systemic medications that may have more cognitive effects out of the system. And then similarly with procedures, there may be a good reason for this, thinking about, how often are we doing Botox, how, effective or adverse reactions are we getting from the oral medications versus a one-time type procedure. So I think next slide. That's it for me. I'd like to thank Hunter's Hope. They gave me the opportunities to start this project and really put the work into this. And then the team at Mass General, Dr. Eichler, and a lot of our research coordinators that have been working hard on this, and some of the families that have really contributed quite a bit to it.
All right, thank you so much, Dr. Wishart, for that